So, well, atrial fibrillation is the most common sustained cardiac arrhythmia affecting over 60 million people worldwide. Catheter ablation stands out as the primary approach for atrial fibrillation rhythm control. However, the limited success rates pose a significant challenge to catheter ablation, especially for persistent atrial fibrillation. Particularly for long-lasting persistent atrial fibrillation, catheter ablation is less effective. And it is also significantly less effective in multimorbid patients. In this study, laser catheter ablation of drug-resistant, long-lasting, persistent atrial fibrillation was attempted in 48 selected patients with multiple comorbidities. A newly developed 1064 compact diode laser was used. This laser was provided with a photon sensor, with a stop button, a roller pump, irrigation tube, flow control, and connecting of the laser catheter itself. Of crucial importance is that photons of this laser are selectively absorbed by myocytes, are unique tissue specific for myocardium and are not absorbed by transparent tissue such as the endo and the epicardium, creating clear-cut homogeneous transmural lesions without tissue vaporization with crater formation. The ablation was performed by using an open irrigated electrolaser catheter in a non-contact mode of radiation and under normal thermic conditions. The catheter is not heated up. It does not transmit heat. Heat is created by absorption of photons by myocytes. The optical fiber tip is mounted 1 mm from the catheter end hole, and photons are transmitted through a clear-cut, optimal pathway created by continuous saline irrigation flow from the fiber tip to the targeted endocardial surface. Therefore, catheter contact force and catheter orientation are not major determinants for lesion formation, and there is no significant difference between lesion sizes produced with or without contact force, and with the catheter in various positions, oblique or flat, so that in flat position, the lesion size can increase with a slightly prolongation of radiation. For left atrial access, site-selective transeptal puncture was performed by using an optical fiber set connected to the laser. For the idle position of the fiber, it is advanced 2 mm by a push-click valve to stabilize the tip upon the selected septal area. With the second push, the fiber is advanced 5 mm and extends with this distance. When the septum is not yet crossed, the laser impact is delivered. Thereafter, the fiber is replaced by a guide wire to assure correct access of the left atria. If this is the case, the steerable sheet is pushed over the dilator into the left atrial cavity. Eventually, wire and dilator were replaced by the laser catheter. Catheter exploration of the atria was performed systematically under X-ray control. A maximum of 26 laser impacts at 15 Watt for up to 16 seconds were applied. A mean of 90 impacts per patient with a mean lasing time of less than 4 minutes. Mean procedure duration was 2 hours and mean X-ray time totalized 23 minutes. Follow-up was in hospital, 3 weeks, 3 to 6 months, yearly, and whenever needed, by the house doctor or the cardiologist. Sinus rhythm was achieved in all patients. However, in 15 patients, redo procedures were needed for various arrhythmias, only in 2 patients for atrial fibrillation recurrence, successfully ablated in one. The other, with improved clinical condition, refused a redo. He is now anticoagulated. 31 patients are under medications for comorbidities, not under antiarrhythmic drugs. Long-term follow-up was 9 months to 19 years. Mean 8.2 plus minus 6.5 years. The long-term success thus is 98%. Left atrial dimensions decreased significantly from baseline severely to moderately in mildly abnormal in 1 to 14 months. Quality of life prior to the ablation was strongly limited and improved significantly after 3 to 14 months. These excellent results were achieved with special procedure, and this was the following. In vivo experimental studies on thigh muscle model performed in the Heart Rhythm Institute, University of Oklahoma, showed that 50 watt steam pop will occur first after 50 seconds of laser application. And the laser is not thrombogenic. Lesion depth was achieved in 10 seconds for about 7 millimeters. In humans, maximum thickness of atrial wall ranges between 0.5 to 7 millimeters, so that at 10 watt, transmural lesions can be anticipated after 10 seconds of radiation. To limit the growth of lesions to the atrial wall and avoid damage of adjacent anatomic structures, temperature control was performed by an esophageal sensor placed behind the left atrial posterior wall. During laser application aimed at the esophageal sensor, growth of myocardial lesions was visualized on the monitor by gradual decrease of electrical potential amplitudes and abolishment after 6 to 11 seconds. Of crucial importance, an esophageal signal was registered 3 to 5 seconds later. Correlation coefficient was 0.9. Thus, with the laser stop 3 seconds after abolishment of EPs, lesions will not grow further and will stay limited to the myocardial wall, sparing adjacent mediastinal structures and including the esophagus, lung, and vagus. The stop of laser simultaneously with a permanent abolishment of electrical potentials amplitude in the high-density mapping electrogram was designated as high-density laser mapping. High-density laser mapping guided posterior wall isolation achieved permanent abolishment of atrial potential amplitudes in 6 seconds. A transmural endocardial lesion was 8 mm in diameter and was without the esophageal damage. For safety reasons, to limit lesion growth to the atrial wall, energy setting was preset to 10 watts and 10 seconds. Therefore, the laser was stopped by releasing the foot pedal because was stopped automatically after 10 seconds. The laser was stopped in case of a stop of because of the stop of potential amplitudes prior to the 10 seconds. After 6 seconds, the laser was stopped by releasing the foot pedal and a transmural lesion was achieved. In patients with electrical potentials were not abolished automatically after the preset 10 seconds, repeated press of the foot pedal extends the laser time with a few seconds until permanent abolishment of electrical potential amplitudes was achieved, so that a transmural lesion could be anticipated. Catheter exploration. Initially, endocardial mapping was performed by systematic catheter exploration of the left atrial cavity. Thereby, various local electrical potentials were recorded, e.g. irregular rapid firing, complex or torsade-like point. In general, we start ablation in areas with irregular firing because these well-defined endocardial regions generating these electrograms tracings were selected. From there, adjacent left atrial and, if needed, also right atrial endocardial regions were stepwise electrically inactivated. With overlapping lesions of approximately 10 mm in diameter, large areas were rapidly ablated by a low number of laser applications. However, it has been shown that cardioneural ablation substantially improves long-term efficacy of AF ablation. This could have contributed substantially to our excellent results because the 1064 nanometer laser wavelengths aimed at the posterior left atrial wall at 15 watts up to 30 seconds modulates atrial ganglion plexi, reduces the inducibility of atrial fibrillation without damage to the SORs. We have not recommended anticoagulation for our patients because discontinuing oral anticoagulation after successful AF ablation resulted in a lower risk for composite outcomes in stroke, systemic embolism, and major bleeding versus continuing direct oral anticoagulation therapy. Thus, it is unique that a laser ablation is a safe and effective rhythm control for long-lasting, persistent atrial fibrillation. It is myocardial tissue selective, is not thrombogenic, and produces clear-cut homogeneous transmural lesions. High-density laser mapping visualizes gradual growth of lesion on the monitor, produces lesions limited automatically to the myocardial wall, and allows immediate validation of success of treatment without the need for other sophisticated mapping procedures. It is a low-power, short-duration, safe, highly effective, user-friendly procedure. With a request of design to cost for competitive products, it is a user-friendly, simplified, multi-purpose ablation system, a highly competitive atrial fibrillation treatment. In addition, artificial intelligence could mark another step towards making tachyarrhythmia ablation more streamlined and accessible. Thank you.